Hello, everybody. Welcome to this session of INICET Sure Short series. So, I'll be dealing with dermatology. I'm your dermatology faculty, Dr. Jazeer Abdul Khader. So, we have curated few of the questions, which is from the most important topics which can be expected in this INICET exam. So, I hope all of your preparations are going good, going fine. So, just few more days for your exams, and I hope that all of you are in track and in good flow of your preparations. So please confirm if my audio and video and everything is clear. So in case that is all clear, I'll just move towards the discussion part of this live session. So what we have done today is like we have multiple MCQs, not the usual format, a little lengthy ones, how you can identify the diseases and how you can make out the right answers, etc. So based on this, I hope that you'll be having a good learning experience today. So now let's begin with the first question. So the question says that a 10-year-old child comes with erosions and blister on trauma-prone areas. What? There is a history of death of a sibling after 10 days with similar illness. What is the most probable diagnosis? The options are epidermolysis bullosa, pemphigus, congenital syphilis, chronic bullous disease of childhood. Now, what is the biggest clue that you have in this MCQ is that it is a child. The patient here is a child. And what is the clinical symptom that the child is having? The symptom is that the patient is developing skin lesions on trauma prone areas. So whenever there is a mention of a trauma prone area in dermatology, we always will have to think about a mechanobullous disease. We have to think about a mechanobullous disease. Fine. So any patient who is having a trauma, for example, my hand, if it is there is a trauma and I develop a bulla at the site of this trauma, it means that it is going to be a mechanobullous disease. Now, there are different types of mechanobullous disease. Either this mechanobullous disease, it can be congenital or it can be acquired. So what do you call for this congenital and acquired forms of a mechanobullous disease? So these are called as epidermolysis. These are called as epidermolysis bullosa. Epidermolysis bullosa. So the question here, the clinical MCQ was about epidermolysis bullosa just from the first sentence, because whenever a lesion develops on a trauma prone area, it is, and if that lesion is going to be a blister, and these blisters may erode, may break to form a erosion. So this is going to give us the clue that this is going to be epidermolysis bullosa. Now, since there is a history of a death of a sibling after 10 days with similar illness, which means that this can be a case of a congenital epidermolysis bullosa. So definitely it is not going to be pemphigus, because how does a patient present to you with pemphigus? In pemphigus, this is usually not seen in a child. What is the age group? The age group where you can find pemphigus is going to be 40 to 60 years of age. 40 to 60 years. Another thing is that in pemphigus, patient do not develop bulla at the site of trauma. Instead, the patient develops a oral mucosal erosions. Oral mucosal erosions can be seen along with vesiculobullous lesions over the trunk can be seen in a pemphigus group of diseases. Now, how does a patient present to you with congenital syphilis? Congenital syphilis is again going to be different, because if a mother is not treated for syphilis and she conceives and delivers a baby, then what happens? Congenital syphilis is possible. Can be either a early congenital syphilis or a late congenital syphilis, but one of the most common symptoms is going to be snuffles. So what do you mean by snuffles? Snuffles means excessive mucus secretions. So this is one of the most common symptoms about by how a baby can present to you with congenital syphilis. Now, the last one, that is chronic bullous disease of childhood. This chronic bullous disease of childhood, this is also mentioned as CBDC, and this CBDC is also called as linear IgA disease. This is also called as linear IgA disease. Now, this linear IgA disease is the most common vesicular bullous disease in a childhood, that is in children. Fine. So here again, this kind of a bulla is not developed at the trauma prone areas, and that is going to be the differentiating factor. So here the right answer is going to be option A, that is epidermolysis bullosa. So that is all about this MCQ. So with your permission, I'll just move towards the next MCQ. So now let's see this MCQ. A 44-year-old male presents to the dermatology clinic for evaluation of his rash. 2 weeks ago, he was diagnosed with non-Hodgkin's lymphoma. An anti-neoplastic drug was started at that time. On examination, the following lesions are noted. Which of the following is the most likely causative? Is it actinomycin, doxorubicin, bleomycin, mitomycin? So from this MCQ, we understand one thing, that multiple drugs are asked. And what types of drugs? These are all anti-neoplastic drugs. So which among the following anti-neoplastic drug can show a side effect like this over the skin? So that is the exact thing that the examiner has been asking here. So what do you see here? You can see multiple marks over the skin. So what are all these marks? How can it be compared to? So these can be compared to a whip-like pattern over the skin. Am I right? So this can be compared to a whip-like pattern over the skin. So what is a whip? We hit by a whip, right? So when you hit like a whip, so we can see a whip-like pattern over the skin. So this kind of erythema is also mentioned as a flagellate erythema. So which is the anti-neoplastic drug which can show a flagellate erythema or a whip-like pattern over the skin? The right answer here would be, anyone, any guess? So the right answer here would be doxorubicin. Sorry. So the right answer here, sorry, not doxorubicin, it is going to be bleomycin. It is going to be bleomycin. So you must have learned about multiple side effects of bleomycin, out of which one of the commonest side effect which you have learned should have been pulmonary fibrosis. Pulmonary fibrosis. So along with pulmonary fibrosis, please remember, in the skin, you can also see this whip-like pattern or a flagellate erythema that is also very commonly seen with bleomycin. So that is the anti-neoplastic drug which can cause this kind of a whip-like pattern over the skin. So that is the explanation for this MCQ, and then we are moving to the next one now. A 30-year-old female presents to the dermatology clinic with complaints of a rash on the face for the past 6 hours. She reports that the rash is itchy. She denies the use of any medication. She further states that for the past few days she has been using a new cosmetic product for her face. So this is one clue for us right now. So there was no medications used, but she's having some irritation over the face. But there is something new. What is new? A new cosmetic product has been used. After a thorough assessment, a diagnosis of allergic contact dermatitis secondary to the cosmetic material use is made. So here in this MCQ, we know what is the diagnosis also. It is going to be ACD, that is allergic contact dermatitis. Now, the product is found to contain methyl chloroisothiazolinone. Which of the following is the main purpose of adding methyl chloroisothiazolinone in cosmetic products? So this is a little difficult question. Now, what is the answer? Does it act as a surfactant? Does it act as a humectant, or act as a preservative, or act as an emulsifier? So what is the right answer? See here, this thing, it may be a little difficult to pronounce, but this is commonly called as the MIT. MCT. Okay, that is, it comes in two forms. It can come as MCIT or MIT, that is methyl chloroisothiazolinone or methyl isothiazolinone. So these are the items which is present in some leave-on cosmetics. So in some leave-on cosmetics, what has happened is this content was frequently causing allergic contact dermatitis. Not only allergic contact dermatitis, sometimes it was causing some kind of a systemic allergy, neurotoxicity as well. Now, because of this, many of the countries in the European Union has banned MIT or MCIT from leave-on cosmetics. From leave-on cosmetics. Now, why this MIT or MCIT was used in the cosmetics is because this was acting as a preservative. This was acting as a preservative. That is the reason why this content was being used. But many of the countries has already banned this MIT. But in India, we still some of the cosmetic products still contain this MIT as well. But please make a note of it, because this has been banned in most of the countries because of the increased toxicity that has been reported to this product, to this MIT. Fine. That is all about this MCQ. Now moving to the next one. A 32-year-old woman presents to the outpatient department with a complaint of a lesion in the genital area that has been causing a discomfort for the last 2 weeks. On examination, there is a soft, non-tender, cauliflower-like lesion on the posterior fourchette. So there is a non-tender lesion that is present over the posterior fourchette. There is no vaginal discharge, there is no vaginal bleeding. There is a history of similar genital lesions which resolved spontaneously. According to the patient, her husband does not have any skin lesion. Which of the following intervention should be most appropriate to prevent transmission? Now, can you tell me, based on these entire clues, what is the diagnosis that comes to your mind? So, what is the diagnosis here? So, this is probably a sexually active patient. There is some lesion over the genital area. And where is the lesion present? The lesion is present over the posterior fossa. Where is there is no bleeding, there is no discharge. There is some lesion which is non-tender and has a cauliflower-like shape. Now, earlier also she had these kind of symptoms, but these symptoms had resolved spontaneously without any treatment. So this is more consistent with what? Yes, this is going to be more consistent with genital warts. So this is more consistent with genital warts. Now let us see the options now. Give continuous prophylaxis to the patient. Give prophylactic antivirals to the husband. Give antivirals whenever active lesions are present, and don't involve in sexual intercourse when active lesions are present. So the question is, which of the following interventions would be most appropriate to prevent a transmission? Prevent a transmission. So here, the right answer here. So in genital warts, always remember, is there any role of antivirals in genital warts? So please remember, there is no role of antivirals in genital warts. In genital warts. So for your exam, these genital warts will be called by another name. What is the other name for genital warts? Genital warts are also called as condyloma acuminata. Genital warts are also called as condyloma acuminata. And remember that there is no role of antivirals. For example, acyclovir, fanciclovir, ganciclovir, any of the antiviral agents that you may know, this has no role to play. Because in genital warts, we usually treat the genital warts with immunomodulators. So we treat it with immunomodulators. For example, some of the examples of immunomodulators can be imiquimod, or podophyllins. So imiquimod or podophyllins can be used as a drug of choice when it comes to the treatment of genital warts. Genital warts are also called as condyloma acuminata. Now, which is the subtype of HPV which can cause genital warts? The subtype of HPV which can cause genital warts is going to be HPV 6 and 11. It can be HPV 6 and 11. Okay, so please remember all these points, and also remember that these imiquimod and podophyllins, these are going to be teratogenic as well. So since both of these are going to be teratogenic, so we cannot use them whenever you want to treat a patient who has just conceived or during pregnancy. So in pregnancy, our drug of choice or the treatment of choice when it comes to a genital warts is going to be cryotherapy. It is going to be cryotherapy. Fine. So that is the right answer. So now coming back to this MCQ, now what are the options given? Give continuous prophylaxis to the patient. There is no point of giving any prophylaxis for genital warts, right? So that can be ruled out. So that is not the right answer. Again, there is no role of antivirals, even if there is active lesions present. So these two can also be ruled out. So what is the best answer? The best answer is don't involve in sexual intercourse when active lesions are present. Fine. So whenever there is an active lesion, if the patient goes into a sexual intercourse, what can happen? The partner can also develop the lesions, correct? So that is the best intervention to prevent a transmission is to avoid sexual intercourse during active lesion. So that is all about this MCQ. So now let's go to the next one. A 26-year-old man visits the clinic with a complaint of reddish skin lesions on the right leg for 2 days. So there are some skin lesions over the right leg for 2 days. So he has no chronic medical condition and he takes no medications. He's a gardener by profession and recalls a thorn prick a few days back. Examination findings are shown in the image. What is the most likely working diagnosis? Now here, one of the clue that we have is that he is a gardener by profession. There is one more clue that there has been a thorn prick few days back. So whenever there is a thorn prick few days back, a thorn prick of a rose plant probably, because he's a gardener by profession, and then you can see that these are the lesions. Now what do you find in these lesions? Now let's see the lesions first. You can see that there are multiple lesions that is present over the skin, and these lesions are arranged one after the other. So they are going to be continuous lesions like this in a linear pattern. So that is a linear pattern. So there is a lesion here, there's a lesion here, one after the other. So what is the diagnosis here? Is it mycetoma? Is it sarcoidosis, sporotrichosis, or Kaposi sarcoma? See, based on this, the answer is very simple. This is going to be sporotrichosis. Now, what happens in sporotrichosis? Sporotrichosis is also called as a gardener's disease. It is also called as a gardener's disease. And what is the causative? Is it a fungus? Is it a bacteria? Or is it a virus? So this is a deep fungal infection. It's a deep fungal infection that causes sporotrichosis. What is the name of the fungus that causes sporotrichosis? It is caused due to Sporothrix shenkai. It is caused due to Sporothrix shenkai. Fine. Gardner's disease, deep fungal infection caused due to Sporothrix shenkai. And here the lesions that develop over the skin usually develops following a rose thorn prick. So the lesions usually develop following a rose thorn prick. So after a rose thorn prick, what happens? The patient can develop multiple nodules arranged linearly. So why are they arranged linearly? These are multiple nodules. These are arranged linearly And these are arranged linearly for one reason. And this reason is that this is along because it runs along a lymphatics. So it runs along a lymphatics. So that is how this deep fungal infection called as sporotrichosis would present. For your exam, please try to remember one more important point here, that in the histopathology, you can see a star-shaped bodies. These are called as asteroid bodies. These are called as asteroid bodies. So these are star-shaped bodies which you can see in histopathology, and that is called as star asteroid bodies. And finally, you can treat this with the antifungal agent. So what is the antifungal agent of choice for the treatment of sporotrichosis? It can be treated with itraconazole. It can be treated with itraconazole. Okay, so that is the right answer here. So here, since it is a Gardner's disease and there is a thorn prick history, the right answer would be sporotrichosis. Now, the other options, mycetoma. So what is mycetoma? So this is also called as the Madura foot, where you get a swollen ankle, isn't it? So the patient has not developed any swollen ankle here. There is no characteristic discharging grains here. So this does not fit into the diagnosis of mycetoma. Whereas in sarcoidosis, again, this is not how sarcoidosis would present. So in chronic sarcoidosis like the lupus perneum, it has a very different type of presentation. And the last one is Kaposi sarcoma. So in Kaposi sarcoma, how can the patient present to you? It can be usually seen in an HIV patient, isn't it? And in Kaposi sarcoma, what is the color of the skin lesions? The patient can present with violaceous plaque lesions over the skin or sometimes over the mucosa as well. That is how the patient can present to you with Kaposi sarcoma. So here the right answer is going to be sporotrichosis. Sporotrichosis. So now let's move to the next one. A patient with complaints of a joint pain and fever was treated with NSAIDs. After a week, he developed a rash on the face, which is shown in the image. What is the most probable diagnosis? So now let's see. There is a history of fever. So fever plus joint pain, that means fever and arthralgia. So what are the diseases that comes to your mind whenever I say fever and arthralgia? So in the options, dengue is correct, chikungunya is correct. So these are the diseases where you can find fever and arthralgia. So this patient who got a fever and arthralgia was treated with NSAIDs. So after treating the patient with NSAIDs, a rash developed over the nose of the patient. So can you see that there is a hyperpigmentation? So you can see that there is a brownish hyperpigmentation, especially seen over the nose of this patient. Now this is a very typical sign of one of the disease. So what is the disease? Yes. So this is called as chikungunya. And what is the name of the sign? The name of this sign is called as chick sign, that is seen in chikungunya fever. So always remember, so whenever you get a patient who complains of fever and arthralgia, it is always better to avoid NSAIDs. So even in dengue fever, we do not give NSAIDs for the treatment of fever. So fever is usually treated with antipyretics like paracetamol. So we try to avoid NSAIDs. So once you treat the patient of fever with arthralgia and with NSAIDs, what happens? The patient can develop something like this, which is called as a chick sign, where a hyperpigmentation can develop over the nose of the patient, and this is called as chick sign in chikungunya. Now, how is chick sign different from the option C, that is melasma? So remember, in melasma, the patient can again develop a brownish hyperpigmentation. The patient can develop a brownish hyperpigmentation over the face, over the face. But this brownish hyperpigmentation is usually not because of any fever. This can be due to sun damage. So by sun damage, what do I mean? Some patient who was exposed to the sunlight and was not wearing any sunscreens, So because of sun damage, a patient can develop brownish hyperpigmentation over the face. It can also be due to hormonal changes. So by hormonal changes, it can be due to any kind of a endocrinology disease, or it can also be because of pregnancy. It can also be due to pregnancy. So these are the common causes of this condition called melasma. So remember, brown colored hyperpigmentation over the face. One of the differential diagnosis would be melasma. But in melasma, remember that the patient will not give you a history of fever. So there is no fever in melasma. The other option that is given in the MCQ was fixed drug eruption. Now what happens in a fixed drug eruption? So in a fixed drug eruption, usually what happens is a patient can develop a hyperpigmented macule. Something like this is possible. Okay, there is a hyperpigmented macule or a patch which can develop, and after a few days this can fade away, but with some residual hyperpigmentation. This is called as fixed drug eruption. So this usually happens, a patient takes a drug, develops this kind of a rash. Next time the patient develops this drug, the rash reappears at the same site. That is why we call it as a fixed drug eruption. So these are all the options that is mentioned here. But in this MCQ, since it is about fever and arthralgia treated with NSAIDs, the answer would be chick sign that is seen in chikungunya fever. That is seen in chikungunya fever. So moving to the next one, a 35-year-old female is being evaluated in the dermatology department for skin lesions. Her medical history is consistent with hypothyroidism and stress disorder. There is a case of hypothyroidism. She is also having some kind of a stress disorder. Hence, she is taking thyroxine as well as sertraline. Which of the following is the likely diagnosis? Is it a polymorphous light eruption? Is it vitiligo? Is it contact dermatitis with henna or dermatitis artifacta? So 35-year-old female, again, let's see the image. So this is a 35-year-old female who has come to our department, and then we know that she is having a stress disorder and she is also hypothyroid. But seeing all these lesions, do you think that this is a case of acne vulgaris or pimples? Or do you think that is it a case of rosacea, SLE or anything as such? No, right? So this looks something like a self-inflicted injury over the face. So what are these self-inflicted injuries over the face called as? So these are called as dermatitis artifacta. So these are self-inflicted injuries. So how can we so confidently say that this is a self-inflicted injury? Because this should be a diagnosis of exclusion, because we have to see whether it fits to the morphological characteristics of any kind of a skin disease. Now, if it doesn't fit to any of the morphological characteristics of any skin disease, then we can consider or categorize it as dermatitis artifacta. So in which kind of patients may show this kind of a dermatitis artifacta? Remember in one of the exams, they had also given a similar image of dermatitis artifacta, and that is usually seen in some prisoners or who are in a jail who just wants to get a medical attention or just wants to come out of the prison. So in all such cases, you may get some in self-inflicted injuries with the cigarette butts over the skin, or it can be seen over the face, etc. So all these are for getting a medical attention. So these are self-inflicted injuries, and remember the terminology that is used is dermatitis artifacta. First one is a light eruption. It doesn't fit. Vitiligo. What happens in vitiligo? In vitiligo, we get a deep pigmented patches over the skin. So deep pigmented means it is again going to look as white in color, but it is deep pigmented because there is a complete absence of melanocytes. And the next option was contact dermatitis with henna, but here there is hardly anything mentioned where we can even think about henna or any contact dermatitis, that is associated with it. Fine. That is all about this MCQ. So now let's move to the next one. So I hope that all of you are able to follow and you're able to understand what is being discussed here. So, and for each of the MCQs, I was just trying to go in detail with all of the options that is mentioned as well, so that your understanding would be better. Because in the exam, the same question may not be repeated, but obviously these are very important topics which are being repeatedly asked for your exams. Fine. So now let's see the next one. Allergic contact dermatitis is a classical presentation of a T cell mediated delayed type hypersensitivity response to as a response to exogenous agents. Yes, that is all about allergic contact dermatitis. It is characterized acutely by erythema, vesiculation, and pruritus. Chronic exposure typically leads to a reduction of the erythema accompanied by lichenification. What is lichenification? It means there is a thickening and hardening of the skin and the persistence of itch. So, which of the following investigations is used to diagnose allergic dermatitis? See, it is a very long question, and the question is basically explaining about what is allergic contact dermatitis, just like how we read any textbook, any standard textbook. So ACD, we know it is T cell mediated. We know that there is a type 4 hypersensitivity. All these points are given. And uh, the second and the third sentence is like, what is the difference between in the presentation of acute and a chronic type of allergic contact dermatitis? Now, what's the question here? The question here is about what is the investigation to diagnose allergic contact dermatitis. So it's such a straightforward question, actually, isn't it? So, what is the investigation of choice for allergic contact dermatitis? The investigation of choice, is it patch test? Is it radioimmunosorbent? Is it eosin binding test or nitroblue tetrazolium test? So obviously, the investigation of choice in allergic contact dermatitis is a patch test. So in patch test, what else can be asked? What is the most common site where we do a patch test? It is going to be the upper back. The next question that can be asked is, when is the reading that is usually taken? So the reading is usually taken with a slight delay of 2 days. That means it is taken after 48 hours. The next thing which can be asked is, when is the best reading that can be taken? So the best reading is taken with maximum delay, and this maximum delay can be up to 4 days, which means it can be 96 hours. So these are the important points about allergic contact dermatitis and patch test. Remember, patch test is the investigation of choice for allergic contact dermatitis. Moving to the next question. A 32-year-old man visits the clinic with a complaint of a painful lesion on the penile shaft and a painful swelling on the left groin region for the past 2 weeks. So, from the first sentence, what do you understand? It's a male patient and is having a painful lesion over the penis. So, which means it can be an ulcer, correct? And there is also a painful lesion on the groin, which means it can also be a inguinal lymphadenopathy, which is painful. Let's see the next sentence. The patient has a history of traveling and unprotected intercourse. On examination, a painful non-indurated ulcer with undermined skin margin is found. So here what you find is a non-indurated ulcer with undermined lesion, undermined margin is seen. A tender swelling is present on the left inguinal area, which means that it is going to be a inguinal lymphadenopathy. Which of the following is not associated with this patient's underlying condition? See, before we approach any of these kind of genital ulcer disease, always try to do this one. Try to differentiate the genital ulcer disease based on painful and painless skin lesions. So what are the examples of painless genital ulcers? The painless genital ulcers, you can always remember it easily with a mnemonic that is called as LSD. LSD is a drug. You take a drug, you may not get to know the pain. Try to remember it in that way. So what is LSD? L stands for LGV, S stands for syphilis, and D stands for donovanosis. So these are three of the genital ulcer disease which is going to be painless. Going to be painless. Now, which are the diseases which is going to be painful? So painful genital ulcer disease. It can be either chancroid or it can be herpes genitalis. So it can be chancroid or it can be herpes genitalis, which are going to be painful genital ulcer disease. Now, based on this very simple thing, can we easily rule out LGV, syphilis, and donovanosis? Because this MCQ says that the patient is having a painful lesion over the genital or over the genital, isn't it? Painful means we are left with only two, that is chancroid or herpes simplex. Now let's see what are the options. Which of the following is not associated with this patient's underlying condition? School of fish appearance. Where do you find a school of fish appearance? School of fish appearance can be seen with Haemophilus ducreyi, which is a causative of chancroid. So this is consistent with chancroid. Next one, gram negative rods. Gram negative rods are again seen as Haemophilus ducreyi. So this is again chancroid. More common in uncircumcised uncircumcised men. Yes, but because genital ulcer disease can be seen more commonly in uncircumcised men. And the last one is cytoplasmic Donovan bodies on biopsy. Where do you find Donovan bodies? Donovan bodies are seen in donovanosis. Donovanosis means the patient is going to have a painless genital ulcer. But in the MCQ, the question says a painful genital ulcer. So what is the odd one out? The odd one out is option D, that is cytoplasmic Donovan bodies is not associated with this patient. It is not associated with this patient. That is all about this MCQ. Now let's see the next one. A 45-year-old male presents to the dermatology clinic with a complaint of a rash over his thigh for the past 2 days. So there is some rash over the thighs for the last 2 days. He also complains of itching, which means it is a itchy rash. And there is no fever. The patient medical history has been consistent with type 2 diabetes for the past 3 years, and the only medication that he is using is the metformin. And on examination, the lesion can be seen. So, a diagnosis of tinea corporis is made, and the patient has been prescribed clotrimazole. After few days, the patient reports a resolution of the symptom. What is the best term that is used to describe this patient's skin lesion? See, once you read the entire thing, you may feel like you have wasted your time reading the entire thing, isn't it? The last thing is actually relevant because the patient comes with some lesion over the thighs, and this lesion is also itching, and then he is a patient of diabetes. He is only on a medication called metformin. Now, after taking a clotrimazole drug, the patient has developing a resolution of the symptom, which means the diagnosis was correct and the diagnosis was tinea corporis. So we also know the diagnosis is tinea corporis. So the question is actually, what is the type of rash that is usually seen in tinea corporis? So do we call this rash as an annular rash, as a discoid rash, targetoid rash, or a nummular rash? So remember that in tinea, what do you find? You get a circular kind of a rash, and this circular kind of a rash is called as annular rash. Okay, this is annular. So why annular? Because this is having a circular lesion. In most of the times, like in this image, you can see that there is a central clearing, and you also in the especially in the cases of tinea corporis, you can see peripheral scaling as well. So there is some raised periphery that which can also be seen in this lesion, what is given in this MCQ. So this is typically called as a annular rash. Now, usually when do you find a discoid rash? Discoid is also, it can be almost oval in shape to circular in shape, but these kind of discoid rashes may ultimately give some scarring as well. Targetoid means like a target like lesion, like you get a lesion like this which is again round, but in the center you may get a small erythematous macule, or you can get a papule or a pustule, and this can be seen usually in the cases of erythema multiforme. Okay, and last one is a nummular rash. Nummular rash can also be a small coin shaped erythematous rash. So nummular means coin shaped erythematous rash. That is going to be nummular rash. This is seen in nummular type of an eczema. But here, since the diagnosis was tinea corporis, the ideal answer here should be annular rash. Be annular rash. So now let's move to the next one. A 26-year-old male presents to the outpatient department with a complaints of a painful lesion at the tip of the penis. Once again, it's a painful genital ulcer. He also experienced a painful swelling in the right groin, which means again it's a painful lymphadenopathy. So we know 2 points now. It's a painful ulcer with a painful lymphadenopathy. The painful lymphadenopathy. So he has a history of unprotected sexual intercourse with a sex worker 8 days ago. On examination, a non-indurated ulcer with undermined skin lesions is seen. A tender erythematous swelling on the right inguinal area is also seen. Which of the following infectious agent is most likely associated? See here, what comes to your mind? There is a painful ulcer and a painful lymphadenopathy. So this painful ulcer and painful lymphadenopathy can be seen in two conditions. What are those conditions? One is chancroid. The other condition can be herpes genitalis. So chancroid and herpes genitalis are those two conditions where we get a painful ulcer and a painful lymphadenopathy. So now let's see the options now. Treponema pallidum. Treponema pallidum is a causative of syphilis. So this can be ruled out. Haemophilus ducreyi is the causative organism of chancroid. So this can be the right answer. Now let's see the next one, Chlamydia trachomatis. Chlamydia trachomatis usually causes LGV. So LGV, again you get a painless genital ulcer. So remember LSD, okay, all these for painless, all these for painless genital ulcer. So chlamydia is also ruled out. And Neisseria gonorrhoeae, they do not cause any kind of a genital ulcer, but it can cause a genital discharge disease. So here the right answer again would be Haemophilus ducreyi based on the entire question. So it is all about whenever you get a question like this, like whenever a genital discharge or a genital ulcer is present, then please try to differentiate between painful and painless, and then try to evaluate with the options. So that you can easily reach out to the diagnosis. So Achan Khan, good evening. Jasim, thank you so much for your responses. So now let's do the next question. So the next question is, identify the hair disorder that is given in the image below. So what do you see in this hair disorder? So one, yeah. Trichorexis invaginata, Trichorexis nodosa, trichothiodystrophy, trichoptilosis. So what is the right answer here? So this is the kind of an image that is given. So even if I don't tell you anything, just by seeing this image, what does it closely resemble to? So this closely resemble to a tiger tail. Am I right? So does it resemble to a tiger tail? Yes. So this is called as a tiger tail banding, which is usually seen in trichothiodystrophy. This is usually seen in trichothiodystrophy. Now let's see what are all these conditions. Now these conditions, all these things are called as hair shaft disorders. So all these are called as hair shaft disorders. So in hair shaft disorders, especially when you are planning to give an INICET exam, so please make sure that this is one of a very important topic here. So there are only 3 to 4 cases which you have to remember, out of which the first one is a trichothiodystrophy, which we have already seen in this MCQ. So what happens in trichothiodystrophy is that the patient can have a sulfur deficient brittle hairs. So the patient can have a sulfur deficient brittle hair, and where you find this trichothiod dystrophy. So in a polarizing microscopy, so this investigation is called as a polarizing microscopy. So in a polarizing microscopy, you can see a tiger tail banding, which is going to be very, very typical for trichothiodystrophy. So there is one more condition which is called as the monilethrics. So monilethrics is also another kind of a hair shaft disorder, where you can find that along with the hair shaft, there are something like a small swelling that happens along this hair shaft, something like this, and these kind of a swelling that is seen over this hair shaft, these are compared to a beads of necklace. These are compared to a beads of necklace that is seen in monilethrics. The next one is trichorexis nodosa, which is another type of a hair shaft disorder. So in trichorexis nodosa, what happens? There is a breakage. So suppose this is a hair follicle. So there is a breakage of a hair follicle, because of which there is a paint thrush appearance. Like two paint brush is going to be pressed over each other. So hence we have this thrush paint brush appearance, which happens in Trichorexis nodosa. So there is a breakage along the longitudinal axis of a hair follicle, because of which a thrush paintbrush appearance can also happen. The last type of hair shaft disorder which you can remember is called as Trichorexis invaginata. So what is happening in a Trichorexis invaginata? In Trichorexis invaginata, again you can see that this can be seen in a type of a syndrome. Now what is the syndrome? Anyone? The syndrome in which you can see this is called as Netherton syndrome. So in Netherton syndrome, you must have heard that what is the type of hair that can be seen? So this is also called as a bamboo hair. This is also called as a bamboo hair, where a patient can develop a ball and socket appearance of the hair. Ball and socket appearance of the hair. So that is all about this these conditions, which is called as hair shaft disorders. So hair shaft disorders, the first one we discussed was about trichothiodystrophy, sulfur deficient brittle hairs, where you find a tiger tail banding. So the other ones are monilethrics, where you find a beads of necklace. Trichorexis nodosa, where you can find a thrush paintbrush appearance like this. And the last one is Trichorexis invaginata, which you must have learned as a part of Netherton syndrome, where the patient is having a bamboo hair and which has an appearance of a ball and socket kind of an appearance. Ball and socket kind of appearance. So that is it. So now let's move to the next one. So the next one is a 25-year-old female presents to the dermatology clinic with complaints of lesions on her lips for the last 2 days. She reports that the lesion is painful. So there is a lesion over the lips which is going to be painful. She reports that there is a burning sensation as well. On examination, the lesions are shown below. Which of the following is true regarding her current condition? So we are looking for the true statement. Central umbilication is seen. Sang smear can be done. Gram-negative cocci and Punt cells are seen. So here you can see that there is a patient who is having these lesions around her lips. Now, based on these kind of lesions, what are the differential diagnoses that comes to your mind? You can see that there is some yellowish crusting that can be seen over the lips area. So whenever you find a yellowish crusting, can you think about impetigo? Yes. So this can be uh, Chan Khan is saying that, okay, let's see what is the right answer. So very good that you are trying to attempt this question. So now let's see. The first differential diagnosis that comes to our mind is a non-bullous impetigo. Because you can see a yellowish kind of a crusting. The second differential diagnosis, what comes to my mind, is that it can be a herpes simplex infection, isn't it? That is herpes labialis. Because you can get a grouped vesicles which can erode, which can give these kind of erosions as well. Now let us keep these two things in our mind. Where do we find a central umbilication? Central umbilication is usually seen in a condition which is called as molluscum contagiosum. But this image does not look like a molluscum contagiosum, so that can be ruled out. Second one is a Zang smear. When is a Zang smear done? Whenever you get a vesiculobullous lesion, you can do a Zang smear. So seeing her lesion something like this, in which one of the differential diagnosis can be herpes labialis, can we do a Zang smear? Yes, we can do a Zang smear. Now tell me, what is a finding of herpes labialis in a Zang smear? So in a Zang smear, we can find multi-nucleated giant cells can be seen in a Zang smear of a herpes labialis patient. Next one is gram-negative cocci. No, because even if the diagnosis was impetigo, is it a gram-positive or a gram-negative cocci? It would have been a gram-positive cocci because the causative organism can either be a streptococcus or staphylococcus. Both are gram-positive cocci. And Punt cells, these are usually seen within Donovan bodies, isn't it? That is seen in Donovanosis. That does not fit here at all. So what is the right answer here? The right answer here is Zang smear can be done. Zang smear can be done. If at all you're getting some of your answers wrong, there is no problem. So it is good that you're trying to attempt, but please make sure that you understand the concepts so that on the day of exam you don't make any mistakes. Fine. So now let's move to the next one. What is the treatment of choice for subepidermal blister formation with neutrophils located at the tips of dermal papilla? So options are rituximab, dapsone, cyclosporin, azathioprine. So what do you think is the right answer here? So now the question itself says that there is a subepidermal blister. So whenever there is a blister that forms within the epidermis, we can call it as pemphigus group. But once it is going to be subepidermal, we find a tense bulla, and there are multiple diseases which can show a tense bulla. The clue here is there are neutrophils at the tips of dermal papillae. So where do you get a neutrophilic microabscess? A very important topic as such. Where do you find a neutrophilic microabscess? We find neutrophilic microabscess in two conditions basically. Like the first one is called as psoriasis, where we can find two types of neutrophilic microabscess. What are those? These are Monro microabscess and also called as the pustule of Kogoch. So Monro microabscess and Kogoch spongiform pustules, these are the neutrophilic microabscess which you can see in psoriasis. Now along with that there is one more disease which is called as dermatitis herpetiformis. So in dermatitis herpetiformis, what you see? You can see papillary tip microabscess. So does it ring a bell now? So neutrophilic microabscess, which can be seen in dermatitis herpetiformis, is called papillary tip microabscess. Where is this papilla present? Papilla is present over the dermis, dermal papilla. So see this question, dermal papilla, neutrophils. So at the tips of dermal papilla. So papillary tip microabscess. So what is the diagnosis in this MCQ? The diagnosis in this MCQ is dermatitis herpetiformis. So in dermatitis herpetiformis, what is the treatment of choice is the question. Is it rituximab, dapsone, cyclosporin, azathioprine? The right answer here would be dapsone, because we treat dermatitis herpetiformis with dapsone. That is the right answer here. So all clear? So with your permission, I'll just move towards the next question now. So a patient presented with a whitish lesion on the upper limb and the penile shaft. What is the diagnosis? So it's a clear-cut spot diagnosis image, and the MCQ is giving you two clues. The first clue is that the lesion is present over the upper limbs. So probably this is the elbow region, because that is what we can make it out from the image. And there is these kind of lesions over the penile shaft as well. So what is it? Is it lichen nitidus? Is it lichen scrophulosaurum, scabies, or lichen planus? Remember, whenever you get these kind of pinpointed papules over the elbow or the shaft of the penis, the diagnosis is going to be lichen nitidus. It is going to be lichen nitidus. So in these cases of lichen nitidus, remember the histopathology is also important in lichen nitidus. So what is the histopathology in lichen nitidus? The histopathology says that there is a claw clutching ball appearance. So there is a claw clutching the ball appearance. Like if it is a ball, so there is a claw clutching a ball appearance that can be seen in this condition called as lichen nitidus. So this is, remember, it is usually seen over either over the elbow region or it can be seen over the penile shaft as well. So that is the right answer here. Now moving to the next question. A patient presented with vesicular lesions over single dermatome over the chest. He also complains of a pain. What is the diagnosis? Now, there is no need to look into the options here because this is a very, very typical image. What do you see? You can see that a patient has developed some lesions which do not cross the midline. And what you see in this image, you can see that there is a background erythema and there are multiple vesicular lesions. Please see this image. You can see multiple blisters, correct? So there is a grouped vesicle. So there are grouped vesicles on erythematous base. There are grouped vesicles on an erythematous base over a dermatomal distribution along with pain. So there is pain, the lesions do not cross midline, the lesions are present along a dermatome, and this is the most common site of what disease? Yes, the reactivation of varicella virus, which is also called as herpes zoster. So this is a typical image of a herpes zoster where there is a reactivation of the chickenpox virus, which is also called as the varicella virus. Now, what is the most common complication that is associated with this condition? The most common complication that is associated with this condition is called as the post-herpetic neuralgia. So there will be a persistence of this pain even after the lesions has been disappeared. So this is called as post-herpetic neuralgia. Hence, because of this, we have to treat the patient with antivirals like acyclovir. And along with acyclovir, we will also have to add something which can take care of post-herpetic neuralgia, which is usually going to be gabapentin. Is usually going to be gabapentin. So that is all about this MCQ. So the diagnosis here was herpes zoster. So let's move to the next question now. A 68-year-old with a tense bulla, and after some time he settles down. Most probable diagnosis here. And this is the image. So what do you understand from this image now? So there is a patient who is 68-year-old elderly patient. So one more clue is that there is a tense bulla. See, anytime whenever you get a MCQ on vesiculobullous disease, try to differentiate it on two things. One, based on the age. Second, based on the characteristic of the bulla. So now let us write down first based on the age. Let's start with children. So what is the most common in children, that is vesiculobullous disease? It is going to be linear IgA disease. It is going to be linear IgA disease. This linear IgA disease is also called as CBDC, that is chronic bullous disease of childhood. Chronic bullous disease of childhood. Now, second one, so this is point number one. Point number two is what is the most common in adults, in young adults. So the most common vesiculobullous disease in young adults, even though we don't find a vesiculobullous, instead we find a papillovesicles here. So this disease is called as, any guess? So this is a disease that is associated with celiac sprue as well. So this is called as dermatitis herpetiform. This is called dermatitis herpetiformis. Now moving towards the next category. And what is the next category? The next category is going to be adults around 40 to 60 years of age. So in 40 to 60 years of age, the most common category is going to be pemphigus group of disease, like pemphigus foliaceus, pemphigus vulgaris, etc. And then the last one is more than 60. More than 60 years or in elderly patients, the most common one is going to be bullous pemphigoid. Most common is going to be bullous pemphigoid. So these are the various diseases that you can keep in your mind. Children with blisters, think about linear IgA disease. Young adults with blisters, think about dermatitis herpetiformis. 40 to 60 years with blisters, think about pemphigus vulgaris. More than 60 years, think about bullous pemphigoid based on age. And then there is one more differentiation, like this is going to be tense bulla. Two types of bulla you can try to remember. One is a flaccid bulla. The other one is a tense bulla. So whenever the lesions are present Within the epidermis, think about a flaccid bulla. So whenever the lesions are present below the epidermis, that is subepidermal, think about a tense bulla. So now let's see the options. 68-year-old man with tense bulla. What is the diagnosis? Is it pemphigus vulgaris? Is it IgA pemphigoid, bullous pemphigoid, dermatitis herpetiformis? So according to the age itself, the right answer here is going to be bullous pemphigoid. It is going to be bullous pemphigoid. Okay? Now let's move to the next one. A 65-year-old man comes to the OPD with a history of fall. He is hypertensive with a history of atrial fibrillation and is presently on captopril, atenolol, aspirin, and amiodarone. He presents with the following finding as shown in the image. What is a probable diagnosis? So there's a patient who came with a history of fall. He's a patient of hypertension and he's having some arrhythmia like atrial fibrillation. So a group of drugs are given: captopril, atenolol, aspirin, amiodarone. So what is being seen here? So now when we see this image, what do you see? You can see that there is a slate gray discoloration of the skin. Can you see this? Okay, you can see that there is a part of the skin which has become a slate gray discoloration can be seen. So which of the drugs can cause this thing? Is it silver toxicity? Is it lupus pernio? Is it amiodarone? Or is it captopril toxicity? So remember that slate gray discoloration of the skin is caused due to amiodarone. So it's a direct question. So here the right answer would be amiodarone induced skin reaction. However, this kind of a violaceous or a violet color rash over the nose can be seen in lupus pernio as well. So what is lupus pernio? This is actually a chronic sarcoidosis. So lupus pernio is the name for chronic sarcoidosis where a patient can develop similarly. But here in this MCQ, the history is going to be more likely towards amiodarone induced skin lesion. So here the right answer would be amiodarone. But remember, on the day of exam, if you get any patient who is having a violaceous rash, especially over the nose, and with a history that is consistent with sarcoidosis, then think about lupus pernio. Then think about lupus pernio. Moving to the next one, following histology is a feature of. Now, what is this? Now, here, what you can see is that uh, leishmaniasis, leprosy, pemphigus vulgaris, mycosis fungoides. First, let us concentrate on the histopathology. So, in this histopathology, you can see that this is the basal layer, isn't it? So, there is a split that is happening. So, this is a split. There is a detachment of the epidermis which is happening just above the basal layer. What is this called? This is called as a suprabasal split. So if there is a suprabasal split, what is the layer in which there is a split happening? The layer is called, what is the layer that comes just above the stratum basale? This is called the stratum spinosum. So in this histopathology, you can see that there is a split in the stratum spinosum. Hence, we call it as a suprabasal split. And in which condition do we see this? This is usually seen in pemphigus vulgaris. So this is a typical histopathological image of pemphigus vulgaris. Now, what happens once there is a suprabasal split? We all know that there are columnar keratinocytes which is present in a single layer in the stratum basale. So once there is a suprabasal split, even these keratinocytes, they get separated from each other like this. So once they get separated from each other like this, What is it compared to? This is compared to a row of tombstone appearance. So this is compared to a row of tombstone appearance. That is about what you can see in pemphigus vulgaris. So remember a row of tombstone, and also remember what is a DIF finding in pemphigus vulgaris. Again, a very important topic or a very important question that can be asked. So in pemphigus vulgaris, remember in the direct immunofluorescence, you can see IgG and C3 deposits in a chicken wire or a fishnet pattern over the epidermis. Over the epidermis. So this is going to be the direct immunofluorescence result that you can see in pemphigus vulgaris, IgG and C3 deposits in a chicken wire or a fishnet pattern over the epidermis. That is all about this MCQ. Now let's go to the next one. A child came with a itchy, scaly, bald patch. Investigation required. KOH, biopsy, GMSA stain, skin slit smear. So what is this? So here, whenever it is a child who is having any lesion over the scalp, always remember fungal infections are very common in the scalp of a child. So if whenever there is a question as such, always go for a KOH mount. Okay. So because there is no point of directly jumping into a biopsy, a GMSA stain can be used, especially when you're using a test, something like a Zhang smear. A skin slit smear is usually done whenever you're suspecting a disease like leprosy. So here, yes, Tapesh, very good. So the right answer here would be a KOH mount, because there are multiple fungal infections that can affect the scalp. So quickly tell me, what are the fungal infections of the scalp? It can be a chirion, isn't it? It can be a favus, which is usually seen endemic to Kashmir. So they can be a black dot or a gray patch. So all these are examples of tinea capitis, that is a fungal infection of the scalp. And all these things are more common in children. So whenever you find anything, a lesion, something like that over the scalp, always go for the investigation, that is KOH is going to be the first investigation. Sorry. Now let's move to the next one. 11-year-old male presents with itchy, scaly, exudative lesions over the popliteal fossa, cubital fossa, and neck. What's the diagnosis? So whenever you find, please keep this thing in mind that for NEET PG, this is a repeat question. For INICET also, remember, whenever there is a child or an adult who is having a recurrent itchy and a scaly skin disease, that too whenever it is seen over the flexural aspects, the diagnosis becomes atopic dermatitis. Dermatitis. So the antecubital fossa or the flexures are going to be the most common sites. You can see here, this is an itchy disease. It's a scaly itchy disease, but there is no mention of any fungal infection or anything as such. The answer here would be atopic dermatitis. So very good. Tapesh is again answering it right. So excellent. So in atopic dermatitis, what do you remember? Like you will have to remember the site of the lesion, because the site is going to be different in infants and it is going to be different in children and adults, because up to 2 years, the most common site is going to be the extensor surfaces. You can just try to remember the crawling infant. Okay, so here it is going to be extensor surface along with the face is going to be the most common site. Whereas when it becomes a children or in adults, what happens? It becomes flexures, which is the most common site of a atopic dermatitis. And this flexural involvement, It is more commonly seen in the antecubital fossa. Is seen over the antecubital fossa. So please make sure that you have a clear-cut idea. If the MCQ says a 1-year-old child or a 6-month-old child with a itchy skin disease, along with bronchial asthma, allergic rhinitis, etc., think about infantile atopic dermatitis. Whereas if the site is going to be the flexures like the antecubital fossa, popliteal fossa, etc., then think about atopic dermatitis that is seen in children or in adults. Okay, this is the basic difference between the sites that you can see. Now let's see the next question. Painful vesicles on genitals. Histopathology would give. Now, where do you find a painful vesicles on genitals? The vesicular lesion, what comes to your mind? So the thing that should come to your mind would be herpes simplex virus. Is it HSV1 or HSV2 in most of the cases? Is going to be HSV2, isn't it? So here you can get a grouped vesicles usually, and these grouped vesicles, if they are not treated on time, what happens? This can go into ulcers that is called as herpes genitalis. So, 2. No, is it Sang cells, Pun cells, Henderson-Peterson bodies, or coilocytes? So please remember that here in HSV, what happens? Pun cells are usually seen in within this macrophages, and which you can see in donovenosis, and Henderson-Peterson bodies can be seen in molluscum contagiosum. Coilocytes can be seen. Where do you find coilocytes? Coilocytes can be seen in human papilloma virus infections, that is warts. So is it warts? Is it molluscum? Pun cells can be seen in donovenosis. Sang cells. So this Sang cells, please remember, this Sang cells can Sang cells along with multinucleated giant cells. These are seen in HSV as well as in herpes zoster virus, varicella virus, etc. So here the right answer would be option A, that is Zang cells. Option A, that is Zang cells. Moving to the next one. Identify the condition that is shown in the image. Is it BL type of leprosy? Is it borderline leprosy, lepromatous leprosy, or histoid leprosy? So from this image, so we know that every type of leprosy, we know that there is a typical characteristics involved, correct? So here, what are the different types of leprosy? In the TT type of leprosy, what is the characteristic? You can get us saucer right way up appearance. Whereas what you see in the next type, that is BT type of leprosy, in BT, very importantly, we can see satellite lesions along with pseudopodia. Finger-like projections can also be seen. So what you see in BB type of leprosy, BB type, you can see a inverted saucer or a Swiss cheese appearance. Swiss cheese appearance, isn't it? Now, the next one is BL type of leprosy, where you can see almost symmetrical lesions. And the last one is LL type of leprosy, where you can find leonine facies and symmetrical skin lesions, plus nodular lesions over the face. And there are many more findings also that is involved with lepromatous type of leprosy. So these are the various type of lesions which you can remember. Saucer right way up appearance in TT, inverted saucer appearance in BB, satellite lesions and pseudopodia in BB, almost symmetrical lesions in borderline lepromatous, and leonine facies, that is lion-like face, nodular lesions over the face, and symmetrical skin lesions can be seen in type of leprosy. Now coming back, if you can find this lesion is usually compared to a borderline leprosy, isn't it? So here the answer would be B because it can be compared to a Swiss cheese or a inverted saucer kind of an appearance. So that is going to be the right answer in this MCQ. That is borderline leprosy. So now let's do the next one. A 10-year-old boy presents with fever, joint pain, and lesions over his hand. Which of the following is a clinical finding and what is the likely diagnosis? So first, let's see the image. So this is the image that you can see here. So in this image, what do you find? There are multiple skin lesions. So can you see that the skin lesions are present here, here, here? So what is actually being spared? The area in between the joints is going to be spared. And where is the lesion present? The lesions are present over the joints, like over the knuckles, over the interdigital joints, etc. So what is this kind of lesion called? These kind of lesions are called as Gottron's papules. So it's a spot diagnosis of a Gottron's papule. And where do you find Gottron's papule? So here, since it is a boy, that is a 10-year-old boy. So here the right answer would be Gottron's papules that is seen in juvenile dermatomyositis. Now what is happening in a dermatomyositis? Dermato means skin, myositis means there's an inflammation of muscle. So the patient would be complaining of a weakness of the muscles along with multiple skin lesions. So here the right answer is going to be Gottron's papules, which is seen in juvenile dermatomyositis. Moving to the next one. A 12-week pregnant woman on multi-drug therapy for leprosy presents with type 2 lepra reaction. What is the treatment of choice for this patient? So here they just mentioned that there is a pregnant woman who has completed 12 weeks. So she's just going into her second trimester and she's already on multi-drug therapy for leprosy. So what is multi-drug therapy? We use dapsone, rifampicin, and clofazimine. So she is on this multi-drug therapy. She's going into a second trimester and the patient has developed a type 2 lepra reaction. So what is type 2 lepra reaction? It is also called as ENL, that is erythema nodosum leprosum. So the patient would be developing some tender nodules over the skin, which is also called as erythema nodosum leprosum as a part of type 2 lepra reaction. So what is the treatment here? Will you stop dapsone, rifampicin, clofazimine and start on steroids? Or will you start on antibiotics? Will you start on thalidomide? Or will you continue the drug therapy and add a steroid? So remember, even in the cases of pregnancy, we will have to continue on the multi-drug therapy and we will have to start on the drug of choice for the lepra reaction. What is the drug of choice? The drug of choice is going to be prednisolone. So the right answer here would be continue MDT and add oral steroids. Will you ever prefer adding thalidomide? No. Reason is thalidomide is going to be teratogenic because thalidomide can lead to a patient who will deliver a baby with sealed limbs, that is phacomelia. So here thalidomide is not preferred because in type 2 lepra reaction thalidomide can also be used, but in pregnancy definitely no. The right answer would be continue multi-drug therapy and start on oral steroids. So now let's see the next question. Match the following scale types with their lesions. So in dermatology, we have different conditions where you get scaling. And many times what happens, we will be comparing this type of scale with something. So this is what is being asked in this question. So where do you find a collarette of scales? So who can answer? Where do you find a collarette of scales? So collarette of scales or a cigarette paper like scaling is seen in Pityriasis rosea. So collarette is matched with Pityriasis rosea. Now 1B. Now let's see what are the options now. 1B, 1A, 1D, 1C. So it is easy. So the option which is likely should be A. Now let's see with the other options also. Silvery scales. Where do you find a silvery white scaling? Silvery white scaling is seen in psoriasis. So that is 2C. So that is also correct. So silvery white scale, psoriasis. Mica-like scales. Where do you find? That is seen in pityriasis lichenoides. So mica-like scales are seen in pityriasis lichenoides. And the last one is brany scales. Where do you find brany scales? Fine, powdery or a brany scales are seen in pityriasis versicolor. Pityriasis versicolor. So here the right answer is 1B, 2C, 3D, 4A. That is option A. So this is an MCQ where most of the scaling which is associated with various diseases has been discussed. So always remember collarette of scales, pityriasis rosea, um, silvery white scaling that is seen in psoriasis, mica-like scales are seen in pityriasis lichenoides, and fine powdery brany-like scaling is seen in pityriasis versicolor. So a 60-year-old patient presents with a lesion given below. He mentions that a spider crawled into the lesion area when he woke up. So which of the following is the likely diagnosis? Herpes zoster, ICD, ACD, herpes simplex. So here you can see that again, this is a lesion where you can see that there are multiple blisters that is arranged in a peculiar fashion, which means it is not going to cross the midline. If it doesn't cross the midline, the diagnosis is again going to be herpes zoster. We discussed about herpes zoster few MCQs back as well. So here the right answer is going to be herpes zoster. So why spider crawling and all? That has no relevance with herpes zoster. Patients can give you different history, but in dermatology, just look into the skin lesion. Don't go to any bias that can happen with the history. So just go to skin lesion, examine the skin lesion, describe the skin lesion, and there you go with the right answer. Is herpes zoster. So now let's see the next question. That consider the causes of alopecia. Which among the following causes non-scarring alopecia? See, there are two types of alopecia. It can be either scarring or it can be non-scarring. So what are the causes of non-scarring is being asked? Question. Alopecia areata, telogen effluvium, androgenic alopecia, frontal fibrosing alopecia. What are the causes of non-scarring? Remember, there are so many reasons for scarring alopecia, but anything that starts with A or T is going to be non-scarring alopecia. So remember this tip. Like what starts with A, what starts with T is non-scarring. So what are the options of A? Alopecia areata is given in the option. Androgenic alopecia is given in the option. Other than that, do we have anything else? So alopecia areata, androgenic alopecia, telogen effluvium, also with anagen effluvium. All these things which starts with A or starts with T is going to cause non-scarring alopecia. So the right answer would be option B, that is 1, 2, and 3. So what are the causes of scarring alopecia? So just let us write down the causes of scarring alopecia. So scarring alopecia or cicatricial alopecia. So this can be seen with multiple conditions. It can be seen with Kirion, which is a fungal infection. It can be seen in discoid lupus erythematosus. So discoid lupus erythematosus can also cause scarring type of an alopecia. It can be seen in frontal fibrosing alopecia. This is usually seen in perimenopausal females, frontal fibrosing alopecia. So it can be seen in dissecting cellulitis, pseudopelade of pseudopelade of rock. So another one is folliculitis decalvans. So all these are examples of scarring alopecia. A Kirion, DLE, frontal fibrosing alopecia, dissecting cellulitis, a pseudopelade of Brock, and folliculitis decalvans. Whereas anything that starts with A or anything that starts with T, remember all these are going to be non-scarring alopecia. Now let's see the next question. A 60-year-old diabetic female patient presents with a progressive skin lesion as shown in the image. What is the diagnosis? So you can see that the patient is having a lesion somewhere around the ears or over the face, isn't it? So you can see some erythema in this lesion. There is some, it's a moist kind of a lesion. There is some reddish lesion that is present within the lesion. So is it a squamous cell carcinoma, basal cell carcinoma, melasma, discoid lupus erythematosus? So here, based on the age 60 and then the kind of lesion, we can easily rule out melasma, because what is melasma? Melasma usually has a brownish hyperpigmented lesion, that too in a middle-aged patient. We can also rule out discoid lupus erythematosus, because discoid lupus can also cause scarring lesions with a central atrophy. Scarring lesions with central atrophy. But this lesion does not fit into that as well. Melasma was ruled out because it was usually going to show hyperpigmented lesions. So now we are left with squamous cell carcinoma and basal cell carcinoma. See, the lesion is over the face. And what is the most common malignancy that you can see, especially over the face? The right answer here would be basal cell carcinoma. Many times basal cell carcinoma, they present with a rolled up border with a central telangiectasia. But these kind of lesions also, because of the area that is present, the more likely lesion or the more likely diagnosis here would be basal cell carcinoma. And what do you call for this kind of a basal cell carcinoma, which is going to destroy the tissue underneath it? So that is called as a rodent ulcer. So this is BCC that destroys the tissue underneath. It's called a rodent ulcer. Going to the next one. A 10-year-old boy has a weakness in the lower limb and a rash over the eyelids. Biopsy shows inflammation of the muscle. What is the finding? Again, we are going to the same topic, because from this image we can see that the lesions are present over the knuckles, over the interdigital joints. So what is it? These are called as Gottran's papules. So these are called as Gottran's papules. So what is the diagnosis here? The diagnosis here is going to be dermatomyositis. The diagnosis here is dermatomyositis. So in these options, shawl sign, heliotrope rash, all these things can also be seen in dermatomyositis, because this is one of the condition where you can find a violaceous or a purple colored erythema. So what is the other disease where you find a violaceous rash? It can be lichen planus. So along with lichen planus, this is another condition where you can find a violaceous rash. It's called as in dermatomyositis as well. That is all about this MCQ. So now let's move to the next one. A female patient presented to the hospital with a history of a relapsing, remitting, mildly itchy erythematous plaques. So it's a female patient. It's a relapsing and remitting, which means it comes and goes. And there is a erythematous plaques. So where do you find erythematous plaques over the scalp, sacral area, and the knees? He has a history of a joint pain. There is joint pain as well, and nail changes. What is your diagnosis? So this is a nail that is given. See, now let's go back to the question and let's read the options. Adult onset Still's disease, paronychia congenita, psoriasis, lichen planus. So patient has a skin condition that comes and goes, and the patient is having only a mild itchiness, but there is lesions over the elbow, knees, scalp, sacral area, etc. And what is a primary skin lesion? Primary skin lesion is a plaque. It's a plaque. And there is joint pains, which means there is arthritis as well. So arthritis, erythematous plaques, and nail changes. So yes, that a hint about psoriasis. That gives a hint about psoriasis. Now, along with that, what gives us more idea that the answer is psoriasis is from the nail finding. So what is the nail finding? Can you see multiple depressions over the nails here? You can see that there is a depression here, there's a depression here, depression here, here. So these are multiple depressions that you can see. So these are the multiple depressions that you can see over the nails. So these depressions over the nails are called as pitting over the nails. So this is called pitting over the nails. So this is called pitting over the nails. So what is the type of pitting that you can expect in psoriasis? The type of pitting that you can expect in psoriasis is called as deep and irregular pitting. And remember, this is the most common nail finding in psoriasis. This is the most common nail finding in psoriasis. Along with that, can you see that in this type of a patient, this part of the nails has turned white in color. Why is it turned white in color? Because there is a distal onycholysis. When the nail gets detached from the nail bed, what happened? The distal part turns white, and that is called as onycholysis as well. That is called onycholysis, where the distal part of the nail turns white. Now, if the examiner asks you what is the most characteristic nail change in psoriasis, so what is the most characteristic nail change in psoriasis? This is going to be the oil drop sign. This is going to be the oil drop sign. Remember, most common is going to be the nail pitting. The most characteristic is going to be the oil drop sign. And when there is a detachment of the nail from the nail bed, that causes whitish discoloration over the nail. This is called as onycholysis. Also called as onycholysis. So here the right answer would be psoriasis. So that is all about this MCQ. So I hope that you had a informative session today. So we tried to discuss some of the important parts or some of the important MCQs that can be expected from different topics in dermatology. So I hope that all of your preparations are going on very well and good. So I wish you all the very best for your exams. So do go through all these important points, important topics, especially psoriasis, vitiligo, genital ulcer disease, genital discharge disease, etc. Because these are usually very commonly asked. Also, please go through the hair shaft disorders and also the common hair findings as well. So these are the commonly asked topics in dermatology, and I hope that you have a great exam ahead. So keep going, and we'll be definitely in touch through the PW MedEd YouTube channel. Thank you so much for watching. We'll come again with